because it's
okay. Going live in 5, 4, 3, 2, 1. We are now live.
Okay, good evening, everybody. Welcome to today's program on the for our DNB and MS education program brought to you by Orthopaedic Research and Education Foundation through OrthoTV. So today we again have the pleasure and the sort of privilege of having Dr. Anil Bhat from Manipal Medical College, Manipal, who's going to talk to us about common entrapment neuropathies in the upper limb. I think it's going to mainly focus on the carpal tunnel syndrome and ulnar nerve neuropathies, which in itself is quite a big area to cover. So as you all know, Dr. Anil Bhat is almost a dedicated upper limb surgeon with a lot of work on hand, other upper limb problems, as well as brachial nerve issues. So with that, I will hand it over to Anil to take today's today's CME education program further. So over to you, Anil.
Thank you, sir. Always a pleasure to come back for you and OREF. And the topic is basically compressive neuropathy, which is a huge area, because most of the upper limb nerves, unlike lower limb nerves, get entrapped during their anatomical course. So there are a lot of areas which are prone for entrapment, all the three nerves. And I'll be basically today talking on carpal and cubital tunnel. Both of them are huge by themselves, and I'll be probably doing as a part 2 of this later for some uncommon neuropathies as well. I'll just share my screen now. Is my screen visible?
Yes, sir.
Yes.
Okay. So, as I said, carpal and cubital tunnel form a big chunk of neuropathies, and the other, probably a little less uncommon, are the radial tunnel syndrome, posterior interosseous nerve syndrome. There's a difference between the PIN syndrome, which is also called supinator syndrome, and radial tunnel syndrome. Probably next time I'll tell what is the difference. Then there's something called Wartenberg and intersection. Median nerve, basically, apart from carpal tunnel, it's pronator syndrome and anterior-interosseous nerve syndrome. And I checked your DNB papers previously, and they've asked anterior-interosseous nerve syndrome. We'll cover that later. And then finally, is the Guyon's canal for ulnar nerve. So these are the major upper limb compressive neuropathies. And I'll start off with carpal tunnel syndrome itself. But before that, I'll just give you a general overview of how these compressive neuropathies play out in terms of, even in your routine practice later in life, how you need to approach this. So you should always make sure that you always examine the spine, the cervical spine, to rule out any proximal lesions, not just the spine itself, even in the neck also. So if you look at something very distally in the hand with a claw, you should make sure that you examine all the way, especially axillary area, and then in the neck, and then go all the way to the cervical spine. So proximal lesions should be always ruled out before assuming that it is a local compressive neuropathy. There could be times when symmetrical lesions can be there bilaterally, and that time you need to think about inflammatory pathologies. Most of the time it's like Parsonage-Turner syndrome or mononeuritis and motor neuropathies. So these are the time when you have a bilateral involvement. And also remember some anomalous connections also. If things are not matching, in terms of your examination, make sure, or rather you start thinking unusual things. And like Martin Gruber kind of anastomosis could be a very unusual connection between the median and ulnar nerve. And so that time the anatomical findings might not really match. The basic workup always should start with an X-ray. Don't forget the X-ray, because there might be sometimes, bony abnormalities causing compression. And a lot of times patients come in straight away with MRI, which is not really correct. So there could be a supracondylar process which can cause compression of the median nerve. There could be malunions, like distal radius malunions causing carpal tunnel syndrome. There could be exostosis anywhere in the body and they can cause compression. Tumors, again, same problem. Okay. MRI is definitely required when we suspect something like tumors, hematomas, and things like that, but they're always not needed. EMG and nerve conduction studies a lot of times help to show where the conduction is slowing, and there are particular patterns of NCV studies which tell that it could be a compressive neuropathies. And ultrasound is coming in a big way. Rather, we have been using ultrasound from almost 2 decades now, and it talks about nerve diameters. Dynamic imaging becomes very, very important. That's a good thing about ultrasound compared to MRI, which is more static, where we can move the nerve and see, and move the limb rather, and see what's happening to the nerve, especially so in ulnar nerve, cubital tunnel, where you can see the nerve subluxating, and all these things can be very nicely visualized. The invasive one, like differential nerve blocks, can be used rarely when there's a lot of doubt about what's happening, and they might give some amount of kind of a pointer to as to where probably the compression is. Most of these compressive neuropathies, remember that nobody, unless there's a gross neurological deficit, conservative line of management is the first. So at least 3 to 6 months of some combination of NSAIDs, rest, activity modification, and some therapy, splints and braces can be used. Rarely we would go for steroid injections, again, not very particular on that. And if all of the above fail, then surgery, which can be either a open or a mini open, or nowadays we tackle most of these with endoscopic releases also. The first one is carpal tunnel. Beautiful diagram from Ortho Bullets, and I took this diagram there just to show how nicely the 3D anatomy can be seen here, and how so you always ask how many tendons, and so there in carpal tunnels we always tell 9 tendons and 1 nerve, and the nerve is the only thing which can get compressed with the transverse carpal ligament here. And all of you know the causes. I won't go a lot of theory details, but basically remember that it's mismatch of the content versus the canal morphology itself. The content size can increase, or more contents can come in, or the canal might reduce because of pathologies, or inherently, like in females, skeletal size can be narrower, and so a little more of mismatch can cause immediate symptoms. Physiological states also, remember, like pregnancy, which can cause carpal tunnel syndrome, and which usually goes away once the pregnancy is over. But most of the time it's pathological. It could be hypothyroidism, rheumatoid, diabetes, any of these things where there is increase in the content size itself. It could be synovitis, it could be fluid, and so many other things. And rare things like anomalous structures can be there. So basically those are the etiology. But at the end of the day, it's just the mismatch which happens. Carpal tunnel basically is clinical diagnosis, and investigations are basically to just confirm or for documentation purposes. I believe very strongly that carpal tunnel is 90% of what patient tells you and what you examine and find out. And rarely it will be just based on only an investigation. Stress on a thorough case history. Always talk to patient, especially how they talk about where the paresthesia is, what happens when they do a particular work, when they get up in the night, what do they do when they get up in the night. So that nocturnal paresthesias, quite early they start getting, and they get up in the middle of the night only because their hand is kind of, in a very awkward position where the nerve is getting compressed, not much of activity, venous congestion, so many factors come in. And they get up and they do this kind of thing where it's called as a flick sign. So some of them give classical history, many might not actually. Okay, so look at what is provoking the symptoms, hand position, movement. So ask them clearly. It could be anything. It could be in the office, it could be somebody is operating, or it could be somebody is doing a machine, somebody is at home doing the housework. Any of these things, ask them specifically at what position or what movements causes kind of paresthesia, what instruments they use, what vibrating tools they might be using, where is the numbness, paresthesia, or pain. Sometimes it could be pain also sometimes, and some radiation. So there's a hand diagram which a lot of us ask the patient to write and mark at least where these symptoms can be located by the patient themselves. Look at predisposing factors, which I told you about. It could be obesity, it could be hypothyroidism, diabetes, rheumatoid, and what actually causes relief of these symptoms, how they can place the hand in a different way, and how it can be used. So that can be checked. Now, if you come to the test itself, all these provocative tests. This is from the American Hand Society, and you know about phalanx and you know about Tinel. Here, Tinel sign is not similar to what you would do for a nerve recovery. Okay, that Tinel sign is different compared to here. It's more of local irritation of the nerve itself, and patient will get that tingling kind of response. Okay, it's an injury, but then it's not like the way we talk about nerve injuries. Okay, and carpal tunnel compression, the Durkan's test is the classical, which has got a very high specificity actually. So this is phalanx. A lot of people do like this, but if you look at the original article of Phelan himself, so this is how he describes it. So a lot of times we don't really have a table to ask the patient to sit and put the elbows like this, so we just do the first one like this. But this is also okay. But make sure all your provocative tests are done for 60 seconds and then mark or document at what point of time the patient is start getting the tingling or numbness. So a person might get even at 10 seconds, somebody might get at 40 seconds. So it just shows the severity of the injury, I mean the condition itself. So this is again very important. And some people, even if you keep them like this, wherever they continuously, I'm already having, you know, paresthesia and things like that. Durkan's is like this, where you really compress the nerve along the course in the tunnel itself. Again, at least minimum 30, but then 30 seconds. But paresthesia within 30 seconds is taken as actually a very specific component here compared to phalanx, which is for 60 seconds. There are so many other tests like 2-point discrimination and of course your NCV. But if you look at this, the evidence says probably there is CTS for NCVs. Okay, so it's not foolproof, but we all do NCVs only most of the time because of documentation itself. Okay, but EMG might tell you actually if there's advanced motor median compression, especially if there are fibrillation potentials, which means the muscle is already getting damaged there. So that is what is the significance of that. So as I said, nerve conduction studies most of the times are for documentation. EMG, ultrasound, as I said, is good because it gives the anatomy of the tunnel. NCV gives the physiology of the tunnel and tells you the pathology, what's happening. And ultrasound basically is checking the abnormal anatomy there. So there could be a ganglion, bifiid median nerves, and also we do measurements also of the nerve across the cross-sectional area before the tunnel, entry of the tunnel, I mean nerve before it enters and inside the tunnel. So we take a difference there. There are particular criteria for that. And as I said, rarely MRI. And when you do NCV, they send you reports with grades. Okay, grade 0, grade 1, very mild, moderate. Okay, not really important, severe, you know, and very severe. Okay, this is what the NCV report comes. But why this is important? It's only because for you to see the degree of compression and then tell that how. Right, a lot of patients expect that the moment you do the carpal tunnel release, next day they should be having complete normal hand. A lot of time it doesn't happen. It also depends the duration, how long it has been compressed, and how severe the compression is. So you need to be very careful with the patients and tell them that just because I operate today means tomorrow you won't be completely all right. It will take a lot of time, especially in severe grades with muscle wasting, and it might not recover because the nerve is lost its. It's been ischemic for so long that it's lost its potential to recover completely. It might recover, but not to the fullest extent compared to when we operate them early enough. So that's the only importance of nerve conduction study. Treatment, as I told you initially, generally how we do, same thing here. We give a splint. Basically, in the night, the splint is given so that the hand doesn't go into extremes of position, either dorsi or palmar flexions. It is kept in the neutral position. We add vitamin B12 and sometimes steroids, local steroids, ultrasound guided we do if patient is not ready for surgery and things like that. Nerve gliding exercises are taught to patient. It's thought that the nerve basically undergoes fibrosis over time because of ischemia, and it gets the gliding of the normal nerve is hampered, and also compression happens. So nerve gliding exercises are the new thing which is coming, and finally surgical. At least 3 weeks of conservative management. Sometimes you can wait up to 3 months. Basically, we do either with open or mini open or endoscopic release. The gold standard, of course, is open carpal tunnel release, either done on a local or a brachial block. A mini open is done with a 1 centimeter incision like this, less post-op pain as compared to open, but they say equal efficacy. Definitely not recommended for beginners unless you know the anatomy really well and you have done enough of open releases. Please go and try this. Otherwise, there'll be sometimes a lot of damage to the nerve itself. A quick video on open carpal tunnel release. So these are the landmarks. Basically, your thenar crease is the first one, okay, and then you go along the about a centimeter ulnar to that, okay. So that is the point you need to take, and the video is playing really slow. Is the same for everyone?
Yeah, it is sort of coming in, not coming smoothly, but it's okay. We can see it.
Is my audio clear?
The audio is fine. It's just the video is in.
Yeah.
Sort of.
So I switched off my video. Hopefully it works now. So what we're doing is drawing the Kaplan's line here, and along the radial border of the ring finger here, and generally that is the distal edge of the tunnel. Okay. So all of you read about the Kaplan's line. So this is your basic incision from the wrist crease. You don't really cross the wrist crease here, and this is the length of the. You can use the entire thing, or you can use a smaller part, and always curve your incision towards the ulnar side, never towards the radial side here, because the recurrent branch of the median nerve comes there. So there is a danger of it getting damaged. So always curve it that side if you want to extend the incision. Otherwise, just stay in the palm. Okay. And once you go into the subcutaneous tissue, you will see the palmar aponeurosis there. And then just make a small, tiny incision there till you just see the change in the color. If you can see, that's the nerve there. So it's right below the transverse ligament. So make sure that you don't go and make a very deep incision there. Just enough for you to see the nerve. The moment you see the nerve, you have to protect the nerve. See, that is the nerve here. The earlier thing was palmaris brevis, actually some muscle fibers. And what you see here is the nerves. The moment you do that, use a McDonald's kind of or a Freer kind of retractor there or elevator, and protect the nerve throughout your surgery now. So everything happens above this. So don't do anything blindly, or don't do anything without protecting the nerve. So that is the release of the transverse carpal ligament. Go from proximal to distal. So that is the transverse carpal ligament which is released, and that's the nerve there. Okay. And you have to check the contents, okay, and see if at all you want to extend, especially in cases like rheumatoid arthritis where you want to do a synovectomy, then only we extend this particular incision. And otherwise, so this is extended here, and these are all the the nerve is retracted here. These are all the flexor tendon, and this is the amount of synovitis which is being cleared by this. Okay, so this is all. So all the 9 tendons. And then finally, you go to the floor of the tunnel there and check for any kind of anomalies are there, any ganglion is there, any lipoma is there. So, and check all these, how nicely they're working. So this just to demonstrate the anatomy itself. And this I put an apical stitch there just to get a good kind of wrist crease back there. And then you suture the rest of it. This is the same. Endoscopic release, either you do a single or double portal technique. It's got a steep learning curve, and surgeon should have a low threshold to abort at any point of time and convert it to an open procedure. That is a message there always. And this is again a quick video, sometimes asked in the recent advances about endoscopic carpal tunnel release. These are the instruments. This is the blade. This is the scope here, and this is the camera. This is the handle for the scope, and the blade itself is the assembly which happens. There's a light source here. We have a synovial dissector here. These are all dilators here actually. That is the assembly. That's how the blade is applied there, and it's locked there. So basically, it's like a gun. When you press this here, the blade comes out here. The sharp blade comes out here. That's how, and you cut the transverse carpal ligament. Okay, so that's a camera coming in and the light source. You can turn the blade and the scope both sides. You can do right or left, just turning on the opposite side. So it can be used both sides. So same landmarks. Okay, here I've just used a little bigger incision just for demonstration, but otherwise I do it in a very smaller incision. So you go between the palmaris longus and the flexor carpi radialis. That's a deep fascia there. and we make a small flap of the deep fascia for us to enter the carpal tunnel here. Okay, so you make a small U-shaped kind of a flap in the deep fascia there and forearm fascia. And once you open that there like that, okay, spread it, you'll see the nerves directly there, and remove that flap, right? And these are the synovial dissector is what? So my hand is here, my finger is here, which means that's the distal end of the tunnel. I don't go, instruments don't go beyond that. This is a dilator going in there. Okay, so you just try to increase the size of the tunnel. Some tunnels are very tight. So you just go along the ulnar side. So you'll feel that resistance by the hamate there. This is called the hamate finder. And once that's done, then you introduce the blade into this. It should go smoothly. If there's very much tightness and all, you need to abort the procedure. Don't go and push it and force it there. You might cause damage to the nerve. So you're basically lying above the nerve here. Okay, and once you go in, this is the picture you see, the endoscopic picture. So this is the transverse carpal ligament. The scope is above the nerve, so you're protecting the nerve completely. These are the transverse fibers here, and this is the basically the distal edge here. You see the fat popping there. So that is the distal edge. You confirm from by pressing from the top, where your finger is or thumb is. So you just inspect once and then go in. This is the proximal edge where I've entered here. Okay, so once you go in the blade, you can push the blade up. You the trigger is pushed up like this, and then you hook that distal edge nicely. So again, important thing is you should see the distal edge very clearly. If you're not seeing very clearly or a lot of doubts, you should not be doing this procedure. You should abort and take. So your consent for patient should always be closed bar open procedure, endoscopic bar open procedure. Okay, and otherwise you'll go and damage digital nerves there if you're not clearly seeing the distal edge of the tunnel. So I'm sorry. I think it got hacked. So that's and try to escape the video. So basically you make a cut through completely. You're not exploring the tunnel with the endoscope. Remember that you're just making a cut through and coming out. That's all. If there's any difficulty at any point, you need to abort that whole thing procedure. I'll just stop sharing and restart this.
Good.
Is it visible now?
Yeah, we can. Yeah.
Okay. So the post-op protocol is mobilization for a week, and then light work by 3 weeks. Scar massage, hand therapy is very important. Complications, scar hypertrophy, tenderness, and what's called as a pillar pain is more of around the ligament itself. There could be injury to nerve, tendon. CRPS type 2 is basically injury to the nerve itself. Patients might have persistent pain recurrence. These are very common. And if there is a lot of wasting of the abductor pollicis babies, we do what is called as a Kamitz procedure, tendon transfer, when there is motor weakness. So basically, this aponeurosis, the palmaris longus, along with its aponeurosis, is taken. Okay, and it's dissected all along, so that you get a long tendon. Palmaris longus stops at the wrist crease. So once you release the carpal tunnel, then you extend the incision. Okay, and then make sure that you've kept the fascia. That is the carpal tunnel there. This is the wasting you see in this patient, right? So you'll have to plan this beforehand. So already we have taken this graft along with the aponeurosis. So we have just extended this like this here, and this is the carpal tunnel. So you have to harvest the graft first, and then you have to do the carpal tunnel release, and then you pass this graft along the. So there's one procedure where the opponent's plasty is not following the rules of having a pulley here. All opponent's plasties should have a pulley to give the better function here. This is one where it goes directly here. Some people do try to create a pulley in the fascia here, but otherwise this goes directly here. Otherwise, always on the ulnar side, you should have a pulley system there for effective function of the abductor pollicis brevis, which is weak, right? So you suture it to abductor pollicis brevis, the capsule there, and also to the sometimes to the extensor aspect here, the expansion here. So 2-3 areas you can suture it so that you get a very good kind of action and opponent's kind of action. So this is a very simple procedure. During a carpal tunnel release itself, you can do this. So patient starts getting that power immediately. Tendon trans within 3 weeks, they can start using their abduction activity if they are very weak and completely paralyzed, right? So this is the anchorage of that, and it needs to sit like this nicely in a good abductor, and flexion is to be easy there. It shouldn't be very tight. Okay, so that is a Kamet's procedure. Remember that one procedure. So diagnosis predominantly clinical for carpal tunnel. Investigations is to know the altered anatomy and physiology, and treatment is based on patient symptom severity. So you can start with conservative management and then go for surgery if it's not responding. Complications are uncommon generally, but then when it happens, it can be quite devastating, especially nerve injuries, recurrent branch, or the median nerve itself. So we have to be very, very careful. These patients really have severe problems and they come back repeatedly, and repeat surgery is not so easy. I come to the cubital tunnel. The sites of entrapment here, basically here is a medial intermuscular septum here. Arcade of Struthers is basically from the medial edge of the triceps here. There are fibrous kind of connections to the intermuscular septum, and they can become quite thick here. And the nerve is basically coming out here. So that can be a hindrance there. And finally, the cubital tunnel here proper, where there's Osborne's ligament here. Okay. This is a dissection in our own cadaveric, this one where you see this, the nerve is piercing the intermuscular septum here at this point. There's a superior collateral artery there. And then if you remove this, this is where this arcade of Struthers is coming in there. I've just ticked off the intermuscular septum. This is from a textbook. This is the arcade of Struthers. This is a medial intermuscular septum, and this is where the ulnar nerve comes, and this is behind the medial epicondyle. And then in the cubital tunnel, this is the Osborne's ligament, and this is the two heads of the FCU where the nerve enters there into the forearm. This is a case we operated. This is a classic Osborne's ligament, but then if you see some muscle fibers are there, this is a very rare anomalous muscles called Anconius epitrochlearis. That is the case I'm trying to show there. Okay, so constricting facial bands, soft tissue abnormalities like synovium, tumor, ganglion. Just now I showed you this Anconius epitrochlearis is an anomalous muscle. Cubitus valgus and bony spurs, and subluxation of the nerve of the medial epicondyle with elbow flexion, especially patients with ligament laxity and any of these collagen disorders. And sometimes it could be occupational related also. Tingling and numbness in the ulnar nerve distribution. Grip is always because the intrinsics are paralyzed or weak rather. Sensory involvement, and a lot of patients actually have more of pain actually in these patients, elbow pain and hypersensitivity. There could be high ulnar nerve palsy kind of symptoms, tunnel sign at the cubital tunnel. If you keep the elbow flexed, hyperflexed like this, again, you're provoking the entire thing. If you keep it for 60 seconds, patient starts getting paresthesia in the hand. And pressure provocation test, you basically put a lot of pressure again over like a Durkan's test. And you can have combined flexion and pressure provocation. Then you might get these kind of symptoms back in the patient. You should know about ulnar paradox here. If you have a lesion quite below here, low ulnar nerve kind of injury, the claw is quite severe. But in a cubital tunnel where the compression might be higher up, this is a case of actually a leprosy patient. The claw is quite mild because of the reason that here the flexors are working. Here they're still they've already been supplied, so they're acting quite well. FDS especially, so the claw is much higher compared to here where all these are paralyzed right from here, so the claw is not so much. So this is called as ulnar paradox. So the lesson is that you have to expose the patient adequately and look for proximal causes always when you see a claw here in the hand. Investigations, as I said, is X-ray, fracture, and arthritis could be problems, medial condylar fractures, arthritis like this can cause impinged carpal. Even cubitus valgus can do that. And NCB and EMG is again, like earlier, as I told, assess axonal degeneration, especially first dorsal interosseous muscle it gets weak soon. Ultrasound, much more in cubital tunnel, it becomes very important to see the ulnar nerve size, the dynamic ultrasound for instability, the subluxation of the nerve itself. And MRI is for rarer causes, if you suspect some tumors and things like that. Otherwise, it's not really required. Ulnar nerve compression, this is an ultrasound picture here, taken again from a textbook. So there's a proximal port, there's a medial epicondyle here, and you see the edema of the nerve here as it goes distally here. So these are the things you appreciate in an ultrasound. Conservative and to start with, and surgery for persistent and recurrent cubital tunnel. And there are salvage procedures also, because here the nerve palsy is quite evident. So people, you'll have to tell them how to place their elbow, when they're working. So a lot of times we place our elbow here and cause a lot of compression here. So that is one thing. Activity modification, you can use braces, and this kind of brace, people use this side splitting in about 45 degrees. So that's what is recommended. NSAIDs, of course, if there is a lot of neuritis kind of component, and steroid injection. Sometimes nerve gliding exercises, something like this, so that all these fibrosis and adhesions can reduce. And of course, ultrasound massage and things like that. Right? Surgical management, either you do decompression of the nerve alone, or you combine with ulnar nerve transposition, whichever routes I'll tell you later, or you take off the medial epicondyle so that the nerve glides easily there. Decompression, open endoscopic release can also be done here of just the Osborne's band or ligament there. It causes less devascularization of nerve, less scarring, and limited decompression. So there might be other sites, like I showed you the medial intermuscular septum or ligament of Struthers. So you need to be careful that you're not missing them. Right? This is the decompression. Osborne's is taken off here, just behind the medial epicondyle where it is attached here. The fascia of the FCU can be released here at this point. This is the distal part. And fascia between the medial triceps and medial intermuscular septum, which is basically an arcade of Struthers. And intra-op, always check the instability for deciding on what's called as an Eaton flap, which is basically a fascia from the flexor pronator fascia here. And transpose the nerve. See how it's sitting well nicely, or every time you flex the elbow, it subluxates. Then you might require something like a sling to keep it there. Okay. This is ulnar nerve decompression and anterior transposition. Don't be, conjuice on the incision. I would like to have a longer incision so that I see the nerve entirely. And I start from the medial intermuscular septum there, all the way down there, and then come all along till the FCU here in the forearm. So make sure you put your finger there and feel for the tightness. Is it like feeling really tight? Then you'll have to go more proximally and release these fibers here. Okay, so a lot of time by feel you can make out how tight the nerve is or how tight the intermuscular septum. Have you really released everything completely there? Okay, so that's very important. And as you come down, then you release the nerve is taken away, and then you start, because a lot of times the nerve is adhered very badly here, so you have to lift the nerve there to see where it's going. Okay, and make sure you don't devascularize the nerve too much. The facial attachments, try to keep them. So that is the Osborne's ligament which is being de-roofed there. So that is the fascia here, and then this is the fascia of the FCU there. Slightly, yeah, that is the FCU fascia. And here I'm trying to go subcutaneous here, rather subfacial kind of anterior transposition with a lot of fat there. Okay, so I would prefer more of a subcutaneous kind of a transfer or anterior transposition most of the time, not submuscular. Okay, but make sure it's quite lax. You just take a couple of sutures in a horizontal kind of mattress here, and then keep it there, and then check after that, after you transposed, check like this so that it's quite lax as you keep moving, flexion and extension. It should be quite lax. It should not be tethering anywhere there. If you see, I've used a sterile tourniquet there so that I can get a longer space there for my incision. This is the Eaton flap taken from a textbook. So you take the fascia from the flexor pronator mass like this, and then make a sling here. Okay, like this. So this is called as the Eaton's flap. If the nerve is really badly subluxating, you might have to do that. Otherwise, transposition is good enough. Indication for medial epicondylectomy is not common. Visible compression from osteophytes and previous fractures of distal humerus. And problem is it can cause higher risk of nerve subluxation. So you will have to be ready for you to do any of these flap or transposition properly, because once you take off this bony support, the subluxation chances can increase. So we have to be very careful how much of medial epicondyle is taken away, and you have to be a little more not so generous on that. Salvage procedure for persistent ulnar nerve dysfunction basically is tendon transfer. So you can use FDS or ECRB or FDS for adductoplasty. Adductoplasty is not commonly described, but this is one area where you can do it. And the FDP of the median nerve distribution can be sutured side to side for the ulnar nerve FDPs, so that they act in unison. So that is an easier way of doing it. One of the new things is the nerve transfer. We use a pronator quadratus branch of anti-intraosseous nerve. We could put it to the deep motor branch of the ulnar nerve. Okay, so that actually pronator quadratus, we have two pronators. So this amount of denervation doesn't cause much of a disability. So that branch from the median nerve is taken, and it is connected to the deep motor branch of ulnar nerve. Especially with this, the intrinsics recover very nicely. So nerve transfer or neurotization, I've talked about this in brachial plexus. So that is the one. I think I'll stop here. This is probably for the next time. Yeah.
Yeah. Okay. Thanks very much, Anil. That was great. Couple of things. One was, I think it's not so common nowadays, but earlier we used to see a lot of these related to Hansen's, ulnar nerve neuropathies with Hansen's, and rarely even with tuberculous infection,
Yeah.
So, and those were kind of, sometimes you'd come up with an abscess in the region of the ulnar nerve, and
Yes.
unless you recognized it and debrided it as well as release the ulnar nerve, it would end up with fairly severe palsies. And the other thing is, when we see some of these post-operative cases of still humeral fractures which have been treated and they come with these neuropathies later, the nerve is so fibrous that even when you've released it, there are times when you feel you need to do an internal neurolysis. So what is your recommendation in those situations?
The first one, even if they come with really frank abscess, I think they do recover a lot of. It's basically it's the pressure. So once the pressure goes, the nerve
release, they do well, unless it's already very fibrotic by the time they come.
Correct. And unless they're fibrotic, and of course the medical management also helps in them. So the combination of that really gives them good results. Now with the trauma situation, post-trauma situation, internal neurolysis is not really recommended. So that's why we have these alternate strategies now of distal transfers now, which used to not be there earlier. So but the release is really important because we still want some sensation to come back, at least the protective sensation. Even if it's really bad, we still do the release and then add up with this distal transfers, or even a tendon transfer is good enough. Especially because by the time the nerve travels down from elbow down to an intrinsic recovery is not so good. So I wouldn't, if the patient is quite disabled, I wouldn't mind adding a tendon transfer, or at least priming the patient about that based on the disability. But the new strategy, what we have in hand now, is a distal nerve transfer. So that's we have been doing it and we have been following up. We have not really assessed them because they're all in the numbers are just 10, 11. So we would definitely want to see how they do well. Yeah.
So what do you do in the distal nerve transfers?
So basically, sir, we take the branch from the AIN to which is going to the pronator quadratus. Okay. So it's a motor branch, and it is neurotized to distal, the deep motor branch. Ulnar nerve. So the donor morbidity is very less. And so the nerve neurotizes, or it's a nerve transfer rather than a tendon transfer. So that's what we do. And the intrinsics, and they recover quite well in this, with the deep motor branch being innervated slowly. And the distance is quite short for it to travel now. It's not that the nerve has to travel all the way from elbow down now. for the recovery. So we are trying to cut short that recovery period also.
Okay, great. So yeah, questions from the delegates or from the participants.
Yes, sir. Also, there are one question which is about the conservative treatment asked by Amagur Saleh. How much vitamin B12 and corticosteroid really help in combination and individually? For how much duration it to be prescribed?
I would not basically go for any combination therapies. One, second, even for vitamin B12, I don't go for combination. You see a lot of these with 100 things inside them. So go for pure vitamin.
Methicobol or something.
Yeah, 1500 microgram is enough daily once. So we give it for 3 to 6 weeks, and generally it's fine with them. Steroid again, it's what I was talking was ultrasound guided local steroid, not
local injection. I think you should avoid steroids in these. I think maybe in a very select situation where you have an acute sort of swelling and things like that, you might think about it, but would avoid steroids, oral steroids or systemic steroids in these conditions altogether.
Because carpal tunnel is okay in the sense that it is the area is quite good enough for you to inject the steroid. And again, with the ultrasound now, I would not really. There are a lot of arguments why use ultrasound, extra cost and all. But for us, it's really not in that way a great burden. So it just costs about 500 rupees for the patient, and patients are ready for that. So instead of doing a blind injection, and so ultrasound guided steroid works well, but for cubital again, not really. At least personal experience, they don't really do well. So we don't really give at all nowadays. We completely stop. And generally in our department or unit, we have never used steroids extensively for anything, for that matter.
I think ultrasound guided injections are becoming more and more popular, not just for the cubital tunnel, but even for some of the shoulder injections, etc., where you be sure exactly where you're giving it. Like if you're, otherwise it's a blind procedure where you're not sure exactly where the steroid goes. So you can be sure that you're not injected into the nerve and stuff, and you're doing it exactly in the space that you want to, because it's quite a tight space in some of these compression syndromes.
These, that's why I said carpal tunnel is much better space compared to cubital.
You have some room to do it, but.
And decoherence also we do the same thing, because especially there might be 2 compartments. So we always use ultrasound guided steroid injections there. If patient, see, these are the patients who are like, they're visiting, they don't want surgery, they want to go back somewhere, they're in, some place, Dubai, somewhere, they come for a short period and they can't afford to have surgery and everything. So this is, and we tell them very clearly it's a temporary procedure. And the next question they ask is, when will it come back or something? Again, no answer for me. I tell them patients are come back at 6 weeks, they come at 6 months, they come at 1 year. So it purely depends on you and your body habitus. So I won't comment on that. It's up to you. You should always give the choice to the patient for these things. You should not take it in our head for these things.
So that is a OPD procedure. They can do the ultrasound guide.
Yeah.
So,
but give them the option. Because don't push the surgery for them. Give them the option. Let them decide always.
And so for vitamin B12, what you have mentioned is that is injectable or oral. Which one you prefer?
Oral. Never injectable.
So there is another question that what are nose gliding exercise as to be instructed to the patients?
Yeah. So as I said, the basic theory behind these are entrapment neuropathies are that the nerve has a gliding mechanism. Okay, it has a areolar tissue and everything, and the nutrition is also good when the nerve is moving nicely and easily, because every time you move a joint, the nerve moves, obviously, right? And now what happens over time, there is some amount of inflammation which happens, fibrosis which happens, and so the nerve gliding reduces. The gliding of the nerve reducing, the fibrosis which happens chronically, all these causes ischemia of the nerve. Okay, and so the symptoms actually become more of a chronic, like carpal tunnel and other things. The compression is not the only problem there always. Okay, so this is what has been found even in the studies where they have checked what the amount of epidural fibrosis which happens and how much of vasa nervosa are damaged. So all these has been documented. So the thought is that you mobilize the nerve and try to, free up all those adhesions, which happen, so that the vascularity improves to a certain extent, right? So there are very specific set of exercises like I showed you in the slide about the guys, cubital tunnel. So there are very specific set of, it's there and anybody can check online. There's enough of those protocols there. And you teach the patient those things, okay? So gently stretching the carpal tunnel area, all these can be done. These are all controlled movements, okay? And so they teach them these things, and so they do well actually. A lot of literature supports this nowadays.
So one question about that subcutaneous transfer, you have explained that result is good. So your experience about submuscular transfer. So even in distal humerus fracture, when we apply the plate, even when we are doing the ulnar nerve, we are releasing, that is in the few literature it is written that it is no need to transfer, even if it is there, that will not cause. So why there is need of subcutaneous transfer, sir?
Again, if you go by the literature, a lot of times there are more submuscular and other things, other routes actually cause more constriction rather than, over time. Okay, at the point of time where you're doing it, it might look gliding nicely, but over time there's always, because even submuscular, you're kind of dissecting much more than you're doing in the subcutaneous area, right? And so these are the ones which cause more adhesions over time and cause compression of the nerve again. So recurrence is a common. So it's proven that the subcutaneous is much more better in terms of reducing the recurrence and reducing the adhesions. Subfacial is somewhere in between, where you really like the way I showed you that flap there, right? Those kind of things can be brought in. But both fascia and muscle cause more adhesions compared to subcutaneous tissue, where it has lost a lot of fat and everything. I think, sir.
Yeah, and part of the trouble is when people try to suture it on too much, because then you get a secondary compression of the nerve. So I think.
Yeah.
So we tend to just lay it on the muscle and then suture the subcutaneous tissue onto the muscle rather than actually suture the.
And finally, the muscle
coming back. That's all.
Yeah, and the muscular action comes in, right, once the patient is moving the joint. So again, there's a little amount of compression there which is happening. So all those adds up at the end of the day.
So one question is about the nocturnal paresthesia in carpal tunnel. So why there is a nocturnal paresthesia? Why
somebody has to just notice how each one sleeps in the night, right? So basically our tendency is to curl up and sleep, and then the hand goes into different positions like when we're sleeping. And a lot of times it goes into palmar flexion, right? Second, there is no activity, we are just lying down there, and then so there is some amount of venous congestion which happens. There's no gliding of the tendons or any of these things. So everything adds up. So a lot of times it's just the position of the hand itself, how it's kept. And so the pressure builds in, and then the paresthesia starts. So this is usually seen very classically in the middle of the night when the patient gets up with severe kind of numbness and paresthesia, right? And then they have to do this. That's called as a flick sign, right? They do a couple of times. They just want to improve the circulation. That's what patients will tell you, but which is true actually, because there's some amount of ischemia which has happened, and that's why the nerve is giving that tingling, that paresthesia sensation. And that's why the splint helps, because the splint keeps the wrist in neutral position. Okay, so that it doesn't go either palmar or dorsal, whichever side, and that's how the splint works. That's the rationale behind it.
So is there any gold standard test, clinical test for this one to diagnose the carpal tunnel? Because sometimes it is very difficult that to rule out the other differential diagnosis. Like there is something like double crush syndrome, if it is there, and something other. So how these things to be ruled out before you're taking someone for surgery?
There is no gold standard test described. It's a sum of all your examination. Okay.
Yeah,
So,
I think you, yes, sorry. I think you need to ideally have your clinical findings, your nerve conduction studies, and your ultrasound correlating to the right thing. Okay. So if you have all these three telling you that it is carpal tunnel syndrome, then I think the chances of you going wrong are minimized. I mean, there may be situations where you have some sort of unusual tumor pressing on it, but that's quite even the ultrasound will be able to tell you that there's something else there that you need to look at. Then you could get an MRI if necessary. But most of these, between these three, I think you cover most things. EMG maybe just to look at how much is damage to the nerves in terms of the motor function, whether you need to do something like a transplant.
it's if your history is not matching the symptoms, so
Yeah,
what
that's what I'm saying.
patient
So
that is your first red flag. Okay. So patient tells I have numbness in all my fingers. Okay. Even the ulnar side and everything and all. So from there you start suspecting. Okay. It might not be just carpal tunnel, right? Then your Phelan's and Durkin's really, 50 seconds, 1 minute, nothing happens major to the patient, right? So start thinking other causes. So then straight away, this next area you should examine is the cervical spine, right? So that could be the major reason. And then any other unusual things. So as I was telling, then correlate it with all your other things. The good neurologist or even, they would give you very nice reports on EMG and NCV for very early stage involvement. But otherwise, routinely just don't blindly depend on the reports. Okay, you do your clinical examination, you get the history, go back and talk to the patient again. That's why my first slide I was talking about the history very clearly. I said also about the hand diagram. Ask them to write or mark where there's paresthesia and everything. And then check and examine all the other nerves. Always. Never forget that. Examine the ulnar nerve, examine the radial nerve. So any time you have doubts, examine all the nerves and see whether anything is involved. Okay. And proximal causes. It could be thoracic outlet is a very commonly this thing. Nobody examines for thoracic outlet syndrome. Okay. I always tell my PGs, neck is fine, that is cervical spine is fine, sir, no tenderness, nothing, movements are fine and all those things. But things are not matching. Ask them to go and examine thoracic outlet, they'll come back and tell, sir, ADSIT's test is positive and Roos test is positive. So one of the common things is like in thoracic outlet, which is quite not very nicely examined most of the time.
Yeah, and it's rare that I don't know, at least in our practice, we very rarely find that the nerve conduction test is completely normal if you have clear-cut symptoms of a carpal tunnel. Okay? I mean, you get some grade of abnormality on the nerve conduction studies, either it's mild, motor, more severe, but very rarely do you get a normal NCV. Do you see that often, Anil?
We have seen, but probably as you said, not in maybe early cases where only
very early maybe
fibers are involved, and they don't really pick it up, or that is the time when they may say normal NCV and they send it to us. I rely a lot of time on ultrasound. Actually, we've been doing it from almost 2 decades now. We have measurements standardized. We have our own normative data. And our radiologists know about it. So they check and tell me the ratio in the forearm versus in the tunnel, proximal and distal to the tunnel, and they compare with the opposite side, the diameters, and give me a cutoff 0.9 millimeters. We have our normative data for our own population. So, and of course, they tell us whether there's any aberrant median artery, bifid median nerve, any ganglion, any anomaly, any synovitis, synovial fluid, all those things they tell us. So because I do everything endoscopic, by default I post all my patients for endoscopic. So for me, the ultrasound information becomes important. So very rarely now I actually convert to open. Very rarely actually. We've done more than 300 cases now. The first 100 cases I used to convert I've converted almost 40% of it to open, because it was the period where I was learning and I was looking at different things. Sometimes I used to not make out the distal edge clearly. I was very cautious initially, so I used to abort immediately the moment. But now I know where I can, go ahead, and so you need to have the cadaveric training, and then you need to keep doing them. Then you know where you can take that a little more extra risk and continue with the endoscopic release. And touch wood, most of them, they do very nicely, and immediately we mobilize. Absolutely no. My only lot of argument again between endoscopic open. When you see mini open and then this endoscopic, the scars, the incision is almost same. Okay, so people tell why you need endoscopy and all those things. My only reason is that there is no scar in the palm. Simple. Absolutely no scar in the palm. So there is no pain. A lot of patients complain of pain because of the scar in the palm there, especially in this area that's called the pillar area. So when they get up from the chair or bed and all, they keep complaining of pain almost 6 months, 1 year sometimes. So my reason is that, and my incision is completely outside the tunnel near the wrist crease, and it does well. That's the only reason I do it. I like to do it.
But as a rule for most orthopedic surgeons, I think it's the open release that they really need to be familiar with. I mean,
Yes,
I think endoscopic release is a specialized area where someone like you or someone who's just who's got a lot of experience in dealing with these could be doing it. Not anyone should not be just trying to do endoscopic releases.
Yeah. So that's why I showed the open release. I didn't show the mini open purposely because of times, because you're doing open release, everybody wants to do mini open and then finish it off. But I've seen a lot of, when I get patients who've been operated outside, a lot of times it's a mini open and there's some damage there when you open up completely. So
some of these you have to release more proximally. Very rarely, again, where the nerve is actually onto the wrist, proximal to the wrist also is compressed. So you have to actually make sure that the release is adequate, even proximal to the, if necessary, proximal to the carpal tunnel as well.
Yes, sir. The video stopped, but one of the steps there is that release of the proximal fascia also.
Yeah.
Can I share it if you don't mind?
Yeah.
Yeah, sure. If it works, that'll be good. Do you have the video separately?
Can you repeat the question?
Do you have the video separately on your laptop?
I have it, but I think
you might
work.
have to look for it. Okay.
Yeah.
Sometimes it doesn't work so well.
It's just that forward it, sometimes it gets stuck. If you just leave it alone, it will play nicely. If you try to drag it and then...
The one you're showing or the open one?
This is the endoscopic one.
Okay.
Because I've shown very clearly there how to release the proximal fascia. In the open, I showed the extended release where for the rheumatoid synovectomy.
Sure.
Yeah. So that is the scope there, and the blade goes over the scope. Blade goes over the scope, and then you just tighten that there. And if you press that trigger, the blade comes out like that. The same light source and camera which you use for routine arthroscopy, for other joint arthroscopy. So same thing can be used. So only thing is the cost is basically of the scope and the blades. The blades are actually disposable blades, and that's the main charge. Scope again is quite expensive. The assembly itself is expensive. So again, this is the pisiform there. That's the palmaris longus here. That's the FCU there. So in the beginning, you need to mark all your anatomical landmarks very, very nicely, so that you don't make any mistake here. So that is the pisiform here. And that is the hamate. If you go 1 centimeter proximal, distal and towards the radial side is your hamate. And that's the Kaplan's interval. Radial border of the ring finger. And the other line is along the web crease, the first web crease like this. I've not marked the entire line. I've just marked the junction there. This is slightly bigger incision. Otherwise, I would go between the palmaris longus and FCR here. This is a bigger incision just for the demonstration between PL and FCU. Otherwise, it will be between FCR and PL. So go here. That is the proximal fascia here. So make a small nick there and a small U-shaped kind of flap in the deep fascia here. So you'll see the nerve right underneath there. Lift off the fascia and tease it out. Sometimes you should be careful if there's a lot of fibrosis, rheumatoid and other things, the fascia is stuck to the nerve there. So be careful with that. So make sure you release only the fascia nicely. And the yellow glistening nerve should be there underneath, slightly dull compared to the fascia itself.
So the proximal release you do open.
Sir. From there only I put the scissor inside and push it.
Okay, so you start from there and then go.
Yeah, it's just by the feel I just push it a little. That's all.
So that is not done endoscopically.
No, that's not done.
Yeah, that makes sense.
So this is called a synovial dissector. So there might be some fibrous bands and everything. So it just frees up all those things so that your scope goes in easily there.
Yeah.
And then the dilators come. There are two sizes of dilators. One small, one big. So a lot of times in our patients, especially, the tunnel is quite tight, and that is one of the reasons I used to abort earlier. But if you dilate it nicely, you'll be able to. We also get smaller size blades nowadays. So for the Indian patients, they have come out with smaller size blades. So it needs to pass in easily. If there's any resistance, major resistance, you should do the entire procedure again. Dilation, everything properly again. So your light helps you. So again, you should not go beyond this line. Always keep your thumb there and make sure none of your instruments go beyond that, because that's where the digital branches are starting off. Okay. As I showed you earlier, you need to see the transverse fibers nicely. Again, if you don't see the normal and transverse fibers nicely, means you're probably in a wrong plane. People have gone into even the Guyans canal sometimes.
Yeah.
So be careful with this. So nicely see these transverse fibers. This is the proximal edge which we went, and this is where you see the fat there. So that is the distal edge there, and it's just a matter of millimeters where the digital branches will start off. So be careful with that. Try to hook it and go along as a single cut. A lot of times it might not happen because there'll be a lot of fibrous tissue and sometimes additions. So all the time, keep your blade pressed towards the palm, as in palmar surface of the palm. And so that is the cut ligament. And what you see that muscle fibers is the palmaris brevis, actually. So that's the cut edge, the ligament. So what you see now is the palmaris brevis coming in there. Okay, this is the distal edge. Some fibers are remaining there. You can go in, and that is the completion of this. So what happens is the fat prolapses. Okay, so I'm just going a little more distally there, and this fat prolapses. So that is where means your ligament is completely released. Okay,
so you don't actually visualize the nerve.
We should not visualize the nerve.
Okay, yeah, that's
the blade is now above the nerve.
Yeah.
So we should not actually explore the tunnel. That is the first dictum in this. You just look at the ligament, cut the ligament, see this fat prolapse sign, and then come out of it. This is what needs to be done. So that's the edge. Just inspect the ligament and come out of it. That's all to be done.
Great. Okay, so any more questions?
There is one more question in the chat box.
Okay.
Any significant role of pregabalin?
People do give, definitely. I mean, neurologists will send me my patients with pregabalin first.
All of them get pregabalin if you
Yes.
look at the prescriptions. I think,
And then I add vitamin B12. I
yeah.
don't really don't take pregabalin because, I mean, it helps to a certain extent. But we know by the symptoms of the patient how bad it is. So I would give them 3 weeks to 1 month and ask them to come back. I don't really push surgeries for carpal tunnel patients because, but if it is too long in duration, the important thing, see, a lot of patients when they come and tell, I have this tingling from 1 month, 3 weeks and all. Don't believe that. Dig in deep. Okay, go on digging. Tell them when it actually started first, and then finally they tell it started 2 years back. I used to ignore it. It was only very little, and now it has increased. So the increased part is where when they come. So once you know it's 1 year, 2 years, you should give a very guarded prognosis telling. The moment I release, it doesn't mean that everything will be all right. Okay, it'll take some time. So tell them straight away 3 months minimum. You will still have some amount of anesthesia on and off. Slowly it will settle down. So counsel the patient that way because that is the truth. Scientific studies have proven that longer the duration of the compression, longer the recovery. Enough articles are there for that.
Yeah. Yes. I think most of the thing we have covered, sir. And the rest of the part we can fix any day for upper limb neuropathies.
Medial tunnel is a very interesting neuropathy. I mean, compressive neuropathy. I think all of them should know.
Yeah, and, just one more thing that remember the carpal tunnel can exist along with a Guyon's tunnel compression of the ulnar nerve. So that's another thing that you need to make sure that you're not missing that out. And so when they have sensations, I mean symptoms in the little and ring finger as well, then think about that as one of the possibilities as well.
Definitely. Always examine all.
Yeah. Great. Thanks a lot, Anil.
Thank you, sir. Thank you.
That was, I think, really useful, and I'm sure all the students and postgraduates would have really benefited from that. So thank you very much, Anil. And we'll stop for that now.
Yeah, thank you so much.
Yes.
Thank you. Thank you, sir.
Thank you.